My name is Togas Tulandi. I'm the professor and chair of Obstetrics and Gynecology at McGill.
Could you start by giving us an overview of the Department of Obstetrics and Gynecology at McGill? What are some of its key strengths and areas of focus?
First of all, the Department of Obstetrics and Gynecology at McGill encompasses several teaching hospitals: MUHC, the Jewish Hospital, St. Mary, Lakeshore, and LaSalle, and also Gatineau. The strength is obstetrics. There are two hospitals under auspices of McGill, which has so-called high-risk pregnancies at the Jewish and also at MUHC. We are referral centers for high-risk obstetrics. In gynecology, at MUHC, we started so-called endo cares, which is endometriosis advances in research and surgery, about 2 years ago. And this is one of the first in Quebec of center treating endometriosis. It's a multidisciplinary center and one of the few centers in Canada. Our oncology is active, and we are active in research as well as in reproductive medicine.
Your department has been at the forefront of advancements in women's health and reproductive medicine. Could you highlight some of the most exciting research themes and innovations currently being pursued?
It's about endometriosis. This is one of our strengths. We found that endometriosis is more systemic disease. It's not just local disease. It's a chronic inflammatory disease. We recruited two mid-career scientists. One of them is Dr. Ribeiro from Brazil. He is a pioneer in so-called uterine suspension before radiation, so to protect the uterus from radiation. And we recruited also Dr. Maria Velez, who has several grants from CIHR. She is a reproductive endocrinologist. But we also recruit many younger people, many graduates. So our department is thriving and is coming along very well.
Looking back, what do you consider the most impactful innovations or breakthroughs that have come out of your department at McGill? How have they influenced patient care or research in obstetrics and gynecology?
I'm a reproductive surgeon, endoscopic surgeon, and we are dealing mainly with infertility. And we have published many papers on this in this subject. Our reproductive center is also one of the centers in which we look after young women with cancers. And we try to preserve their fertility. I think that is very important for our reproductive endocrinology and infertility. Our oncology gynecologic oncology is coming along very well. Our obstetrics is, again, as I said, is a referral center for many from other physicians outside. Our surgery is mainly now endoscopy, so it's less by open technique. And we have 6 minimally invasive surgeons in our department. And I mentioned that the endometriosis is one of our recent program.
For students in the Surgical Innovation Program, how can they engage with research or clinical projects in your department? Are there specific areas where their skills in engineering, AI, or medical technology could make an impact?
We encourage all our trainees to do research. In fact, one other thing that I didn't mention is we have annual McGill Symposium in Women's Health. It's every September. We have been doing it for many years. And during this symposium, we also have dedicated time for research. So the trainees are presenting their research projects, and the best oral presentation will get the best, and second best will get awards, as well as the best poster presentation will get award. So we encourage our residents and fellows, of course, fellows are publishing, and students, if they want to do study with us. And we have a lot of papers coming up from our trainees. We are just starting doing AI, and in fact, one of the talk in our symposium is artificial intelligence in medicine. Yeah, and I think eventually everything will be more AI related.
How do you see the future of obstetrics and gynecology evolving, particularly with the integration of technology and interdisciplinary collaboration? What role do you think departments like surgical innovation can play in shaping this future?
The fact that we are at MHC, we are many specialties under one roof, which is great. In this so-called EndoCares, the Endometriosis Center, it is a multidisciplinary program in which it's not just obstetrics and gynecology, but also urologists, colorectal surgeons, thoracic surgeons are involved. So this is multidisciplinary, and in terms of research, we are collaborating with different services, including Dr. Montroy from social medicine and somebody from kinesiology. I encourage multidisciplinary programs because or multidisciplinary research team, and also by having multidisciplinary team, for us it facilitates getting grants. AI is being implemented in our program, and we also do a so-called video consultation, mainly in ultrasound with Dr. Gagnon. So we are giving expertise to places outside Montreal, such as in Nunavik. So they send us the pictures, and then they ask to basically to read it. Several of our physicians, obstetrician gynecologists, they go to Nunavik and also to Sisasibi. So serving the Inuit community as well as the Cree community.
Could you describe any innovative surgical techniques in your department?
I think I mentioned about uterine suspension. We have been doing so-called ovarian suspension also for cancer patients. Surgery has evolved from just open up the patient and to endoscopy. One of our program now as well is so-called V-nodes, which is vaginal natural orifice surgery. That means instead of doing laparoscopy from the abdomen, we do it from vagina. So this is an innovative technique, and again in our symposium that in September we'll have somebody also talking about this. Just quickly, maybe for those who want to become a surgeon, training is important. It's not just specialty training, but also subspecialty training. Like my surgery is surgery for mainly for women who wants to conceive, and it's not just surgeon skill. Skill is very important. If you don't know, you're not good with your hands, then you should not become a surgeon. And the other thing is skill is not everything. You should have the knowledge, and you should have a good clinical judgment. It's just like doing surgery. For women who wants to get pregnant, they want to get pregnant. We just people do surgery, and then they decreasing the chance for the patients to get pregnant instead of increasing. So good surgical judgment is very important. Good clinical judgment. I'm a surgeon, but not everything needs surgery. You have to really judge what the patient wants, what's the best for the patients. There are many surgical techniques. Some of them stay, some of them disappear, but minimally invasive surgery stays. It's good for the patient, the recovery is faster.
Could you tell us how you got into this kind of surgery? And perhaps what led you into this path?
an obstetrician gynecologist, and then did fellowship in reproductive medicine, basically, reproductive endocrinology and infertility. So I'm more interested in infertility. My surgery is for infertility surgery because we were one of the first doing endoscopic surgery. People are sending us other conditions such as hysterectomy to be done by minimally invasive surgery. So I become minimally invasive surgeon more than IVF specialist. And then, we published papers, we did research, and people started to know us, and they invited me all over the place. So it's and I became the president of Society of Reproductive Surgeons in the States and Canadian Fertility as well. So, but again, I think my message to everybody is surgery is great, but not everything needs surgery. And if you do surgery, you have to do it properly. Depends on what's for the best of the patient, and good clinical judgment and good surgical judgment, of course. First of all, I like to see more research, of course. That's how we do innovation. In Quebec, maybe operating time is a problem. Not just for us, for all surgeons. We have not much operating time and being cut, so that's a problem. For the future is we like to recruit specialists, not only to do surface, but also to contribute academically, research, teaching, and not just in our specialties, but what I like to do is I like to recruit people with a degree, another degree, maybe in education, and we are doing it. Degree in simulation. We just recruited somebody else as well. Degree in research, PhD, that we recruited one person, clinical scientist. So those are the things. So this is so we are not just providing this is an academic institution. We are not just providing service for the patient, but we also providing teaching, education. So this is what I want. I want people who certainly energetic, new people with different degrees besides specialty or subspecialty training.
Finally, what advice or message do you have for prospective students considering research opportunities within your department?
The advice is you got to be curious. Not everything in the book is correct. So you have to always ask yourself, is this correct or not? That's how we get research. But also they have to be persevere. They have to really doing research, because what happened is sometimes our trainee, they are keen at the beginning, but at the end, not at the end, and then nothing happens after. We want it published. We want it good research, and we want it published.